With that, I'm very happy to introduce Professor Chad Meyerhofer. Professor Meyerhofer is the Arthur F. Searing Professorship for the Department of Economics. He is the chair for the department and a research associate with the National Bureau of Economics Research. His research primarily focuses broadly on the economics of health and nutrition and involves using microeconomic methods to evaluate and inform public policy. He's published over 50 peer-reviewed journal articles, in addition to several book chapters, conference proceedings, research reports, and so on. So, with that, I'm going to pass it off to Chad Meyerhofer so we can talk about the epidemic of obesity in terms of the economic impacts, GLP-1s as medication, policy implications. I think this will be a very interesting conversation in talking about GLP-1s from a different lens than I think most people are typically presented. So, with that, Professor Meyerhofer, why don't you take us away?
All right, thanks a lot, Bryce. Thank you to everyone for joining me today. So what I'd like to talk about is the relationship between obesity, its cost, particularly in terms of healthcare spending, and then talk a little bit about the cost of treatment and GLP-1s in particular. So as you're all aware, obesity is a serious condition and can contribute to or cause a lot of chronic medical conditions. So type 2 diabetes, cardiovascular disease are the most common and some of the most costly to treat. But there's actually quite a few conditions linked to obesity in the medical literature. And this is why, medical doctors, policymakers have been very focused over the past several decades in coming up with treatments that are, successfully able to jointly treat these conditions and lower body weight. So as an economist, I like to put things into a cost benefit framework. And so part of, when we think about like coming up with treatments that are sustainable, we have to make sure that those are cost effective. And that starts with measuring like the cost of obesity, which is actually pretty difficult given how obesity affects so many parts of our biology and is related to other, social factors. So obesity certainly, generates numerous costs, but the ones that we typically focus on are elevation of medical expenditures and reductions in productivity at work. And then, of course, it lowers quality of life. Now, some of these, there's a fairly large literature on, for example, the relationship between obesity and medical expenditures that I've contributed to. There's a little less information about productivity effects because, while we can measure, say, how frequently somebody doesn't come to work because of a chronic disease, like it's much more difficult to determine how much less productive they are at work because of some condition. And then, of course, quality of life is the most difficult because it's somewhat subjective in terms of how it's measured and benchmarked. But we can all agree that as a general principle that the cost of the treatment for any condition, including obesity, should be lower than the cost of the condition itself. And that's assuming like, we can monetize all of these costs. So one issue that I've, spent a lot of my own time thinking about is how we estimate the cost of obesity. And so this right here, what I'm showing you is a schematic of an economic model of obesity. And I'm not going to go over this in detail, but just the way that we tend to think about it is that individuals make decisions that maximize their own well-being, which we call utility. And so they take their income and then they purchase things like food, they spend some of their time on leisure, and then they leverage available public goods to increase their utility. All those things, their level of food consumption, the type of leisure they do, like public goods that are available, say like parks and recreational facilities, those also affect their body weight, which in turn affects their health status. And how healthy somebody is very important to, their welfare, how they feel about themselves, how their state is. And so if we wanted to try to model all that, we could, and some people do. And each of these like arrows in this graph would be a separate mathematical equation. And we'd have variables and data to measure all the boxes. And we could try to determine how this like individual level model of utility maximization works. But that's extremely difficult. And so a lot of times, instead of measuring like all those individual pathways, what we do is we try to get a very good estimate of how changes in, say, body weight cause higher medical expenditures. So we take all those little arrows and we kind of package them into this large arrow that I'm showing you. And we have data on body mass index, which is how we typically measure body weight. It's basically weight for height. And we have data on medical expenditures, so we can pretty easily, using statistical methods, come up with a correlation for this. But the problem is that correlation doesn't tell us what we refer to as the causal effect. It doesn't tell us like how changes in body weight cause higher medical expenditures, because there's some important things that we don't observe, and those can cause the correlation to be different than the causal effect. So, for example, access to care. People have different levels of access to medical care because they have different types of health insurance. They have different knowledge about providers. The communities they live in are different. They speak different languages. And so there's a lot of things there that we don't measure very well. And because like access to care will affect medical expenditures and potentially your body weight, it can kind of cause us to fail to be able to like determine what this effect is. Like what's typical in this literature is the fact that people with low access to care, they'll have lower medical expenditures, but they tend to have higher body weight. And so when you try to estimate this using a simple model, you underestimate the effect of changes in body weight on healthcare costs. So the method that my co-authors and I have developed is to use genetic information, which is not related to other factors like socioeconomic status or access to care, and use variation in body weight that's only due to changes across the population in genetics to identify the relationship, the causal relationship between body mass index and medical expenditures. And the idea is that, genetics is like a lottery. It's like a natural experiment. And so if we think about it that way and we isolate that variation in body weight that's just due to genetics, we can actually determine how changes in body weight cause differences in medical spending. Now, one of the challenges with that, of course, is that the data sets that are available that have body mass index and have medical spending, they don't contain individual genes. We are starting to get more data that contain genetic information, but it's still at a pretty early stage. So instead of using data on genes, we use a proxy for genes. And in particular, we use the child's body weight as a proxy for the genetic composition of the person as it determines body weight. So we use the child's body weight as a linkage to tell us something about the parent's body weight. Now, the only reason this works is that it turns out, and this is kind of surprising, I was pretty shocked when I learned about it myself, is that family environment has actually very little effect on body weight, which is a bit counterintuitive because we think about the fact that like families eat together, they participate in recreational activities together. You'd think that, what the family does really determines body weight. But it turns out that individual genetics and environment, individual choices actually are the biggest determinant of body weight. And there's lots of studies in behavioral genetics that validate this. So for example, there's been adoption studies where they look at like the body weight of adopted children, and they find that it's basically uncorrelated to the weight of their adoptive parents. But then when they link them to their biological parents who they never live with, there's a very high correlation in their body weight. Likewise, there's studies that look at siblings who are raised in different families, and despite being, in totally different environments, they have a very high correlation between their body weight. So, there's a large literature on this that suggests that family environment is not important, and that means that that's not going to confound the relationships that we identify using the body weight of a relative as an instrument for the person's body weight. Okay, so we use the body weight of the relative to cause essentially random variation through genetics in the individual's body weight, and then we can map out the relationship between body weight and medical care costs. And so the first paper that I co-authored on this was published in the Journal of Health Economics in 2012. It's now one of the most highly cited papers in that journal. And that was with a friend and colleague, John Colley at Cornell. And since then, we've expanded this method, we've refined it and improved it. We've looked at a lot of things like how it relates to chronic condition status, labor market costs such as productivity and absenteeism. We've extended it to adolescence. We've done state level estimates, and we've looked at like technical issues and how the estimator works. And so a result of that modeling is that we've been able to map out how, excuse me, how medical expenditures, which is what's measured on the vertical axis here, how those expenditures change as body weight changes. And this is a causal effect. So this is essentially how changes in body mass index will map to medical expenditures. And so there's a couple of things that, like the first time I generated this graph, I found surprising. They told me some things I didn't know. So there aren't a lot of people in the US with low body weight that's below like the underweight range, but there are some. And so you can see that, if your body weight is very low, your medical expenditures on the left-hand side of this graph, they're elevated. Most people in the US during the sample period here are kind of split between the three weight categories of healthy weight, overweight, and obesity. And so the dotted line in the background here is essentially the probability distribution of the population. It's centered in the overweight range. It's like the average American is overweight. So one of the things that's really interesting is that there's really no difference in healthcare costs for people who are at healthy weight and people who are overweight. And we'd actually had some studies very early on mortality that were, were consistent with this sort of finding. But it's not until, your body mass index goes into the obese range, which is at a BMI of 30, and actually passes 35, that medical expenditures really start to rise. But then when they do rise, they rise very quickly. And so, the finding from this analysis is essentially that, the consequences, the cost consequences of higher body weight don't really become significant relative to a normal or a healthy weight person until your body mass index goes above 35. And if you look at this for adolescents, it's pretty similar. So in the case of adolescents, we use the Z-score, so the percentile of their body mass index to measure overweight and obesity and healthy weight. And so here, the difference, I guess, is that in the overweight range, you do see medical expenditures start to go up, and then they go up very sharply after you hit like the 95th percentile, which is the cutoff for obesity in adolescents. But generally speaking, it's the same dynamic where, that the costs essentially rise very quickly at high levels of body weight. Okay, so we were able to estimate from these models the total medical care cost burden in the United States from obesity. And I've done that. We did that in earlier studies, so I've inflated those to $20, $25, so they're easy to think about. And so what our models suggest is that obesity increases total medical expenditures, and that's like costs paid by insurance, private insurance, public insurance, and individuals all together by about $350 billion a year. When we look at work loss, we're able to measure like work loss days, meaning like how often people, failed to show up for work because they had a chronic condition caused by obesity. So we're not able to measure like how productive they were at work, but those costs are close to up to $36 billion. And then quality of life is not something that I've studied directly. So what I did to calculate this number is I just used sort of standard quality of life factors that are associated with chronic conditions caused by obesity. And so it's a very back of the envelope estimate, but those quality of life costs are very high. We would measure those at about $546 billion a year. So if you're using like a very inclusive measure of the cost of obesity, it's like 922 billion. If you're using a narrower measure that is the one that like insurance companies or federal policymakers usually pay attention to, which would be medical expenditures predominantly, maybe with work loss, it's more like $385 billion a year. Now, that's a big number. How big is it? Well, I find that a useful benchmark is to think about the total cost of the Medicare program. That's 540 billion. So the total cost of obesity is treatment, treating obesity directly and indirectly is less than the cost of the Medicare program, but not by a lot. So it's approaching that cost. So it's very, very substantial. Of course, healthcare costs in the United States are high in general relative to peer countries. So we spend 18.5% of our GDP on health spending, and that's $5.6 trillion a year. All right, so the costs of obesity are substantial, which means it's important to develop treatments that can address those costs and improve quality of life as well as lower medical and productivity costs. And right now, the predominant treatment is GLP-1s. And so GLP-1s have come on the market relatively quickly. If we think about how long other types of weight loss programs like Weight Watchers or other types of, nutrition-based programs have been around. GLP-1s haven't really been around that long. And even if, considering like when these drugs were developed, it's only very recently that they're becoming more common in their position on the formularies associated with most people's insurance or where on the formulary they are. So whether they're like a preferred branded or a non-preferred branded. So how GLP-1s work is somewhat complicated, but they have like a neurological component. They also work through insulin secretion in the pancreas, but you can think of them as an appetite suppressant. So they make you feel more full. They reduce hunger, and that indirectly lowers, it affects insulin secretion and blood sugar, but essentially they work through your brain. And um, they do have side effects. So, nausea is a common side effect of GLP-1s, and there's others. At this point, we haven't identified like, serious long-term side effects, which makes them a fairly attractive treatment. There's a series of medications that were rolled out, but the initial ones, which were developed for treatment of diabetes, they weren't widely adopted by insurance companies. So it's not until we had semaglutide on the market, which is Ozempic and Wegovy, and then more recently tirzepatide, which is Zepbound, that we've really seen the availability of these medications increase significantly. Now, they are relatively expensive. So then the question becomes like, how do we finance these? How do we justify the costs? So, so what we have done with our research is these are estimates from our model. We can take that J-shaped cost curve that we identified, and we can translate that into like how much medical care costs would go down if you go down that curve, meaning like you reduce someone's body weight with a medication, how much of a savings in long-term medical care costs will that achieve? And so this graph shows us like for every starting BMI from 30 to 45, if you achieve, say, 20% weight loss, what are the annual savings? And so that's the purple line that's on top there. So for example, at a BMI of 40, if someone starts at a BMI of 40 and they lose 20% of their body weight, they're going to save a little over $5,000 per year in total medical care costs, them and their insurance. And then different percentages of body weight, you save less. So 5% is this light blue curve at the bottom. And then we also looked at like how this is affected by whether the person has a chronic condition or not. So the one that we looked at was type 2 diabetes. And as you can see, if you have somebody with type 2 diabetes, then the savings that they achieve from a reduction in body weight is a lot greater than if they don't. And so these cost curves are the reason why a lot of insurance companies will limit coverage to drugs for, say, people on with type 2 diabetes or people whose BMI is above a certain level. Okay, so the cost of GLP-1s varies significantly depending on, your insurance plan and other factors. The list prices are quite high. It can be, the list price of these medications, 12 to 16,000 a year. But if we look at like the cost to a typical insurer after, drug companies will give insurance companies rebates depending on how much of the drug they purchase. So if we look at the cost net of those rebates, they're around, $4,800 to $9,600 a year. And for a patient, their out-of-pocket costs, if they have insurance, can be as low as $300 roughly, or as high as $6,000. Now, if they don't have insurance coverage, then, they're more in the range of $3,600 a year to as much as $12,000 a year. Our latest estimates of how much we're spending now on GLP-1s come from a paper just published in JAMA Network Open. They calculate that we're spending around $71 billion on GLP-1s. So New England Journal of Medicine studies showed that the typical weight loss from tirzepatide is about 20%. It's about 14% from semaglutide. So based on our estimates, like the long-term savings then from these are, these are what they are at a couple starting BMI levels. So that, at a BMI of 35, it's about $1,600 a year, but at a BMI of 45, if you're on tirzepatide and you're losing 20% of your body weight, that's going to save around $30,000 a year, year over year in medical spending. And considering annual treatment costs, and this is across like the patient and the insurance company, are between $5,000 and $15,000 a year, it would suggest that the threshold for, to kind of break even, if we're just considering medical care costs, obviously quality of life will change things a lot, but just considering medical care costs, it's approaching a BMI of 40. Now, recently, these medications were made available on this new Trump RX platform. And so for individuals with insurance, they would cost them less to get the drugs through their insurance. But if they don't have insurance, then they can access these drugs for about $4,000 to $6,000 a year, depending on the dosage. And then the last thing I just wanted to mention really quickly was that these GLP-1s have been included in the second round of Medicare price negotiations. And so by 2027, we'll have negotiated prices through Medicare Part D plans for semaglutide, so for two of these drugs. Now, the problem is by statute, Medicare cannot cover drugs for weight loss. So what CMS is doing is they're using like demonstration products through the Innovation Center to bring in, tirzepatide as well as, expand the availability of these medications. So there's something called like a Medicare GLP-1 bridge that starts this year, where actually, access to these drugs can be had for just $50 a month. So that's going to significantly increase access to these medications, these negotiated prices through Medicare. So I want to stop there and then let anybody who wishes, ask a question about what I talked about, or just like talk about anything related to this topic.
Yeah, wonderful. Thank you, Chad. So as you said, everyone, if you have any questions, please feel free to go ahead and submit those into the chat, and we can have an open discussion about that. One thing that I did also want to do, that I meant to do at the beginning of the presentation, but I forgot to, so I'm going to launch a poll real quickly, just to get a sense of the audience is in the room today. So, just a couple of quick questions. What is your Lehigh affiliation? And then also, if you are an alumnus, what decade did you graduate within? So I'm gonna launch that now. So if you wouldn't mind, go ahead and completing that while we kind of answer some questions, that would be great. Um, so Chad's kind of looking at a couple of questions that I had. So how looking at BMI specifically, obviously, is kind of it's a well-regarded and well-held standard of overall kind of general health. But is it something that is kind of the most effective way of being able to evaluate it? And I don't know if this is necessarily a fair question, but I'm gonna ask it anyway. Because like for BMI, like I feel like when it was initially founded, like the average body weight of a person in the 50s and 60s is different than what it is in 2026. So, would there be other qualitative factors or other factors that health insurance companies or researchers could explore in kind of evaluating the cost effectiveness? So, for example, like my BMI, technically by the NIH calculator, I am technically obese by their definition. I'm 6'1", about 230 pounds. But that can range very differently by how much body fat I have on my overall lifestyle. So if you were to look over at this research in terms of the overall cost, if there was a better way or another alternative that you could explore that wasn't BMI, would there be other factors? And do you think that they would be, potentially any better or worse than kind of the research that you've already done?
Yeah, so the reason why we use BMI is that we have measurements of it.
Mhm,
It's not an ideal measure. And it's probably the reason why when you look at this cost curve, you really don't see anything happening until BMI starts to exceed 35.
mhm,
Because obviously, like these definitions, overweight and obesity, those, you can tell by the names, they're sort of imply that bad things happen at a BMI of 25 starting then. Maybe they do, but in terms of mortality and in terms of medical care costs, we really
mhm,
don't see anything in the overweight range. Um, the well-known problem with BMI is it doesn't account for muscle mass, and so
mhm,
that's an issue. And what really matters for health are several things. And I'm not a cell biologist, but I've been in enough discussions with them to know some things. And what matters is the percentage fatness, which is not exactly the same thing as BMI,
mhm,
where the person is carrying their fat. Like if fat that's carried around the organs is much more damaging to health than fat that's carried around muscle.
mhm,
And then the type of fat cells. So like the size of the fat cells varies depending on different things. And so there's certain types of fat cells that are much worse for health than others. And if you had better measures, then you would be able to pinpoint, you'd be able to target individuals more effectively for interventions. It's just that right now, like all we have is, you go into your doctor's office, they weigh you and they know your height. So that's what we have at the moment. I mean, in the future, like, DEXA scan is, one that's been, or, body weight scans like have been used to like determine percentage fatness, but like their early versions of those weren't very accurate either. So in the
yeah.
future, there'll be better clinical measures.
Yeah, it makes me think back to your point earlier in the presentation. I thought that was so interesting that the genetic aspects of children and their families, and there was less of a connection between the environment that they lived in and more of a connection just to like what their genetic makeup was.
Yeah.
And I wonder how much of that, like, if there's, opportunities to dig into that research further to see, like, maybe is there a particular genetic makeup that would be better suited to semaglutides, GLP-1s, or, different types of interventions? Like, what are your thoughts on that?
Yeah, so we call that precision medicine, and that's basically using a person's genetic information to select the medications that will work most effectively on them.
Hmm.
There's like a lot of precision medicine in like cancer treatments and other things. We haven't really gotten to that point with weight loss yet. There is like, these genome-wide association studies that are mapping out like which SNPs, which are single nucleotide polymorphisms, like which ones are more highly correlated with high body weight.
Mhm.
So we're getting to that point, but we haven't really integrated it as much into medical treatment. But that's like something on the horizon.
Gotcha. All right. And just as I had hoped when I asked my two questions, the chat went off, and now we've got a bunch of questions that we can explore.
Right.
Okay, so I guess we'll just start from the top down. So Janet Wheeler, what is the cost structure when those medications come off of patent protection?
Yeah, so it changes quite a bit. Because that I think that happens in 2031 for Ozempic, and then it'll be after that for other drugs. But it makes a big difference. So usually, the way your insurance works is, you have a generic copay, you have what's a branded preferred copay, and then non-preferred branded, usually it's more like you pay a much higher percentage, and there might be like an annual out-of-pocket limit.
Mhm.
So, generic is going to be like if we look at this out of pocket range here, like somebody who's paying like $300 a month is uh, a very generous insurance coverage for a branded medication. But when that's a generic, like that's going to go down to like $10 a month. So it's going to be like $120 a year when it becomes generic. But the problem is it's going to be quite a while before that happens. And a lot of times, by the time a drug becomes generic, there are other treatments available that are more effective, and people have a hard time, they even though it's cheaper, they often want those more expensive medications. So even like tirzepatide, which was introduced much will become generic much later than semaglutide. You can see like the average weight loss is 20% versus like 13.7%. So that's a newer drug. It's going to be branded for a much longer period of time, but it's more effective.
Yeah, potentially at a higher premium cost too because of
Yeah.
its effectiveness. Okay, so it sounds like we got a couple of people who are highly educated on this, significantly more than me. So Cole asks, when looking at the relationship between BMI and medical costs, have you looked into using the Mendelian randomization methods to determine the direct effect of genetics on medical costs expenses? That's a mouthful.
Yeah, so we haven't yet. It's something we're probably going to do next. It's actually something that I do in my other research. So, um, Mendelian randomization is essentially a more targeted version of what we did. So what we did is we used body weight as a proxy for genes. In Mendelian randomization, you use the actual genetic information. So you have a data set that has where somebody has had a blood draw, and so for each person in the data set, we know like which genes they have. And right now, there's no data set that has genes and medical care costs. Like there's one that has out-of-pocket medical care costs, but not like the costs that are paid by the insurance company and things. But there's this new data set that we're looking into called All of Us that I think does have more information. The problem, I mean, so some of the problems with the methodology that we use also affect our problem with Mendelian randomization, which
Mhm,
gets into like, certain genes can affect like multiple things. And so, you have issues where if you want to know the effect of like obesity and heart disease, you can't use a gene that affects obesity and heart disease both. It has to just
mhm,
affect obesity. So, like in my other work, I have other work where I look at the effect of oral health, like periodontal disease, on heart disease. We use not just Mendelian randomization, but like a structural equation model to like improve that method. And
mhm,
I'd love to do that with this. It's just a matter of getting the correct data. But yeah, it's a
mhm.
great suggestion.
Right. All right. So I just want to preface everyone with there's many questions here, so we may not be able to get all of them in the remaining time. But please feel free to reach out to me, and I'm happy to forward any additional questions to Professor Meyerhofer. Nahid asks, so how do the costs of side effects affect the overall cost savings, and have these side effects been factored into the cost saving figures that you've seen?
So the answer to that is no, they haven't. So nobody's really looked at like the cost of treating the side effects. So they're not, I mean, certainly that would reduce like the cost benefit if we did that. The treatment of the side effects is really not significant with these drugs. Like where we've done that, where I've seen studies that do that more is like bariatric surgery,
Mm,
because initially like side effects from bariatric surgery were pretty significant. Recidivism rates were pretty high. And so it mattered a lot what to, calculating those side effect costs was really important. For these medications, because the side effects are more limited, no one has done that. Although it's certainly, with better data, I mean, part of the issue is like, a lot of times these data sets have prescription drug costs. They don't have like over-the-counter information. So to the extent that like you're treating your side effects using over-the-counter medications or changing your diet, we can't really measure that. And that's probably one of the reasons why people haven't done it.
okay. What about incorporating age? Was age ever a factor that you were evaluating when kind of looking at this? So Bill had asked, is there a relationship between BMI, healthcare costs, and age specifically for the elderly? So are older populations potentially more or less at benefit for GLP-1s, or how are potentially insurers looking at someone's BMI and incorporating their age? Like, what are your thoughts on looking at age as a factor?
Yeah, it's interesting and very, very relevant at the moment because of the coverage by Medicare of GLP-1s. And so one of the limitations of our research is like this, like this chart that I showed you here is only for like working age adults. That's the sample we used to generate that because we had to have information on the children. And people who are older, their children don't live with them, so we don't see their characteristics
Mhm.
in the data. So we haven't been able to do this study specifically for people like over 65, but we could, there is a data set that gives us like out-of-pocket costs for that population, but not total costs. And actually, like most of these costs are borne by insurers. Like
Mhm.
90% of, especially when you get into like these very high tail costs for people with BMIs over 40, like 90% of those are paid by the insurance company. The relationship, like based on other methods, the relationship is similar, for people who are older. It's just that it becomes a little bit more challenging to map out trajectories and body weight because people, will at a certain age, their body weight just starts to go down naturally due to the aging process. But I think, studies also show that, like for example, like if you smoke and you smoked all your life, like there's still a benefit to quitting smoking at like 75 years old, even if you smoked, from 15 years old till 75 there, which is, despite the fact that you've obviously had some damage to your body from all those years of smoking, you still benefit from quitting at that
Right.
time. And I think, body weight is like that too. So there's still a benefit from reducing body weight if it's in a certain range, even for people who are older and had been like heavy most of their lives. But it's definitely an area we need to know more about.
Yeah, absolutely. So we've got about 5 minutes left, folks. One of the things that I did also want to acknowledge with the upcoming week is tomorrow and Wednesday are Giving Day and March Mania for Lehigh. So if you want to continue to support Lehigh and continue to support the economics department, so I just dropped a link to the Giving Day March Mania page for the economics department and for Professor Chad Meyerhofer. So if you're planning on donating, you join this presentation today to engage with Lehigh and to support the research that's been done. These funds go towards supporting faculty, go towards supporting research and supporting students. So if you're inclined to give a gift, then we would certainly appreciate it as we go into our largest fundraising event of the year. So that's my small plug. We're now going to get back to a couple of questions before we kind of wrap things up for the day. So. There was one question that I wanted to look at for chronic conditions. Yes. So Liam asks, hi Chad, really interesting work on the economics of GLP-1s. Did you mention that payers are more or less likely to cover GLP-1s for patients with existing chronic conditions, i.e. diabetes? I would think it's more advantageous to prescribe slash approve a GLP-1 before a chronic condition exists. So what is as outside of diabetes, what are some other potentially chronic conditions that might be supportive of something that a GLP-1 might benefit from. And are there pre-existing conditions or like tendencies for pre-existing conditions that maybe if they weight decreases earlier, then they may be able to prevent themselves from getting those chronic illnesses.
Yeah, it's absolutely a good point. And it's a great point, and it's a difficult argument sometimes to make with payers like health insurance companies, because like they're looking at this graph, and they're saying like, oh, well, these are expensive medications, and if the person already has type 2 diabetes is being treated for it, I'm going to save a lot more money, paying for the drug for those patients.
Hmm.
But in the long term, you absolutely would save more if you lower body weight at the outset and then you don't incur those future costs. The
Hmm.
problem is, because health insurance is tied to employment, a health insurance company is only going to be responsible, for that individual as long as they're working for that company, or unless they transition, like when they retire, to their Medicare Part D plan. So they don't have that's like a flaw, a fundamental problem with our system of health insurance is that health insurance company doesn't really have full ownership of that individual. If they did, like if they were on the hook of, for covering their medical care costs their entire life, then they would absolutely change the way they finance the medications and do it at an earlier stage. But like right now, the conditions that will usually trigger coverage for a person, diabetes is one, um, various types of heart disease is another, sleep apnea is another. And so there are some insurance companies that are more generous that will, they will cover these drugs just based on body mass index alone. But there are a lot that will only do it if the person also has a chronic condition, whereas you may think like if the person is what we would clinically diagnose as like pre-diabetes, that if they're pre-diabetic or if they have like early stages of fatty liver disease, then you would really want to cover these medications. But right now, that's not the criteria because companies are looking more at the short-term cost savings than they are at the long term.
Gotcha. It's funny that you say fatty liver disease. The next question that I was going to bring up was actually about fatty liver. So Janet adds, fatty liver is increasing exponentially, and weight loss is the first line of defense to stop it or reduce it. Wouldn't the use of a GLP-1 for that condition be a benefit? I think
Absolutely, yeah.
largely, yeah, sure.
Yeah. No, I mean, for individuals, yeah, because fatty liver disease and diabetes are, are the two conditions where there's like a very strong independent effect of body weight on that condition. So like, in a very simplified way of explaining it, like body fat, affects directly insulin secretion.
Mhm.
So you can develop type 2 diabetes from, having high body weight, and fatty liver is like that. So, um, it's an interesting, yeah, like, one of the reasons is that some of the, coverage decisions that insurance companies make is based on evidence. And so,
Mhm.
because early on, like we did this study where we looked specifically at type 2 diabetes, we generated the evidence for that condition. But there's other conditions where when you look in like the data we use, they're nationally representative, but they're not, they don't cover everybody. We just don't see enough patients to estimate the model, and then you don't have as much evidence. And so there are gaps in coverage sometimes because of that lack of like scientific evidence.
Wonderful. I feel like this is a conversation that we could continue to have for many more hours, but unfortunately for our time today, we have reached our time. So I wanted to take a moment and thank Professor Chad Meyerhofer for his time in preparing this presentation as well as presenting it. Certainly feel more educated on the topic, and it's one of the things that I love about getting to do these talks is getting to hear from experts who really know the data and know the implications of it. And thank you to our audience for taking the time out of your day to join us. As I mentioned, if you're hoping to continue to support Lehigh, programs like this are a great way to do that, as well as donations to the university to a cause of your choice. There's many different opportunities beyond just the economics department for the College of Arts and Sciences, the College of Business, as well as student programs and much more. So. Thank you for your time, everyone. We look forward to seeing you all in our next edition. But for now, enjoy the rest of your week and have a wonderful day.
Yeah, and feel free to email me directly. My email's on the website, and if you have further comments or questions, I'm happy to communicate with you that way.
All right. Wonderful. Thank you,
Yep.
Chad. Thank you
Yep.
to our audience, and we will see you guys next time. Have a wonderful day.